All right, everyone. Today, we're diving deep into the world of arthroscopy. But we're not just talking about its use as a diagnostic camera. We're going to focus on its real power as a therapeutic tool. We'll break down exactly how we match specific arthroscopic techniques to three completely different kinds of joint problems: degenerative, inflammatory, and infectious. Let's get right into it.
So, let's start with the basics. What exactly are we talking about when we say arthroscopy? At its core, it's our surgical gateway for treating problems inside the joint. Think of it as our minimally invasive window. It lets us perform targeted procedures without the major trauma that comes with the full open arthrotomy. It's a game changer. Okay, so before we jump into specific diseases, we really need to understand the tools in our arthroscopic toolkit. What can we actually do once we get that scope inside the joint?
We're going to zero in on these three core procedures. First up, synovectomy. That's the surgical removal of diseased synovial tissue. Next, joint debridement. You can think of this as a mechanical cleanup of the joint. And third, drainage and lavage, which is essentially a high-powered, aggressive washout of the joint space. Each of these is designed for a very different pathological situation.
Now, let's put these principles into practice. We'll start with our first clinical scenario, and it's the one you're going to see most often: osteoarthritis.
So with osteoarthritis, or OA, we're dealing with a chronic, irreversible process of degeneration. The problem here is fundamentally mechanical. It's that classic wear and tear that just grinds down the cartilage over time. This then leads to all sorts of secondary issues, like bone spurs, osteophytes, and loose bits of cartilage and bone floating around in the joint.
It makes sense then that our arthroscopic solution is also mechanical. We perform a joint debridement, which is really just a cleanup job. We go in there to fish out all that debris, the loose chondral and osteochondral fragments that cause those classic mechanical symptoms like locking and catching. We can also trim up degenerative meniscal tears while we're there. Now, the goal isn't to cure the OA, we can't, but it's to improve how the joint works mechanically and give the patient relief from those very specific symptoms.
Okay, let's completely switch gears now. We're moving away from a mechanical problem and into the realm of a fundamentally biological one: the inflammatory arthropathies.
In diseases like rheumatoid arthritis, the enemy isn't mechanical wear. The primary aggressor is an autoimmune-driven synovitis. The synovial membrane, the lining of the joint, goes rogue. It becomes this overgrown, invasive tissue called a pannus, and it actively starts destroying the cartilage and bone. The pathology is literally coming from the synovium itself.
So logically, if the synovium is the problem, our intervention has to target the synovium. And that procedure is called a synovectomy. We're doing a targeted surgical removal of this diseased tissue. You could say we're literally removing the engine of joint destruction. Now, this is what's really interesting here. Synovectomy has a dual purpose. On one hand, yeah, it's palliative. You remove the inflamed tissue, and that directly reduces pain and swelling. But and this is the important part: if you do it early enough, it can actually be prophylactic. By removing that invasive pannus, we can potentially slow down the disease's progression and prevent secondary damage like those tendon ruptures that are so common in RA. This takes it from just a simple procedure to a genuinely disease-modifying surgery.
And this slide just lays it out perfectly. You can see the huge strategic difference. In OA, we use debridement to treat the effects of degeneration, the loose bodies. In RA, we use synovectomy to go after the source of the inflammation, the synovium itself. One is mechanical, the other is biological. It's all about choosing the right tool for the right pathophysiology.
Finally, let's tackle our third category. This one is an acute, incredibly destructive condition that is a true orthopedic emergency: septic arthritis.
With septic arthritis, we are in an absolute race against the clock. The bacteria that have set up shop in the joint release these proteolytic enzymes that just digest the articular cartilage. We're talking destruction within hours. So the number one goal is immediate aggressive source control. We have to get the bacteria and all that purulent gunk out of that joint, and we have to do it now.
Arthroscopy is a fantastic tool for this. The approach is multi-pronged and aggressive. It starts with a thorough drainage of all the pus. That's followed by an extensive lavage. We're talking about flushing the joint with liters and liters of fluid to dilute the bacteria and wash out all those inflammatory mediators. We'll often combine this with a debridement to remove any dead tissue and fibrin, and sometimes even a synovectomy to get rid of infected synovial tissue.
So let's pull all of this together. What are the big take-home messages? How should we really think about the role of therapeutic arthroscopy in our day-to-day practice?
The most important thing to remember is that arthroscopy is not a one-size-fits-all solution.
Its real power is in its adaptability. For osteoarthritis, it offers a mechanical solution for a mechanical problem. For rheumatoid arthritis, it's a biological solution for a biological problem. And for septic arthritis, it's an urgent, aggressive intervention for an acute infection. You have to match the procedure to the underlying pathophysiology.
And that leaves us with one final thought to chew on. We've neatly separated these things into mechanical and biological buckets. But what's coming next? As our techniques get better and we develop new biologics, are we going to see a future where we do a mechanical debridement for OA and at the same time deliver some kind of disease-modifying drug right into the joint? The future of orthopedics might just be in blurring that very line.